I know we've just...
Yep. Sorry, thought it was automatic. Sorry, everyone. So for those of you online, we're just getting started on unit discussions. So your first assessment task is week 4 and is a quiz. The quiz will only be 20 minutes and it will effectively be open book, but you're going to be pushed a little bit for time. Obviously, there'll be ECGs in it, and you'll also have short answer questions in relation to those ECGs, primarily around exploring, I think the assessment outcomes kind of say it all, but exploring your pathophys and the provisional diagnosis, but also your management plan, and starting to talk a little bit about the evidence for why you would and wouldn't do things in out of hospital care. So that's kind of that foundational quiz that we're looking for you to be comfortable with. It's only a 25% assessment, so hopefully it's kind of relatively low stakes. What we're looking for you to have by week 4 is that you're pretty comfortable with your steps of ECG interpretation. As we go through the semester, we're going to use those steps for ECG interpreting each week and talk about them in the context of patient presentations, which leads me to assessment task 2 and 3, where you will have a written critical analysis, and you'll get a case study given to you in week 4. So at the end of the first assessment task, you'll get your case study for the next assessment task, and that will be your case study for your written assignment, which is due in week 10. The other unit coordinators and I have tried to map out your semester so that you don't have everything falling into individual weeks. So if you need to put in for extensions for those sorts of assessment tasks, just keep in mind that we have planned out your semester so that you have one due every week sort of thing. So it might impact you quite significantly. This assessment is due in week 10. So if you have to put in a new extension task, remember you have 4 assessments in your exam period. You also have an assessment for 246. So just keep in mind that it's due in week 10, but you're really pushing a large part of all of your weightings for your other units as well at that time. So that'll be a critical analysis piece where you basically just sort of discuss the evidence around the treatment for the patient that you decide based on the presentation. And then your last assessment task is Aviva. So I don't know if you guys would have had Aviva for any of your units yet. Maybe 214, would have you had Aviva before? So effectively, it'll be a Zoom meeting, much like this, where you'll be at one-to-one with an examiner, and you'll be asked to, they'll ask you questions about what you've learned in the unit. They'll probably ask you to interpret an ECG, maybe 1 or 2, and also describe your reasoning behind it and your thought process behind it. So that's kind of like the assessment side of things from the unit perspective. But I think what's really interesting about this subject is that really people want to come away being able to interpret ECGs and apply it in context. And I think that that's a really key important part of this unit. So if you have questions or you're not sure, make sure that you keep engaging with the unit. Even if you're falling behind in the work, just keep putting the questions into the Padlet at the summary tutorial page at the end of each week, because I'll keep looking at those questions and that'll be kind of the basis for how I look at what we're going to cover in the week's tutorial content. So yeah, I guess that's kind of a bit of admin. Is there any questions from the admin sort of side of things? Yeah, go on, Jazz.
Just a question. So the Viva, is that like our final exam? So that's in our exam period?
Yes.
Yep. And AT 1, 2, and 3, they're just individual assessments.
AT 1 and 2. So AT 3 is the Viva.
Is the Viva? Yep. And so there's no formal exam, like a written exam at the end?
Oh, written exam. No written exam.
Okay.
Yeah. So the only quiz you'll have is that first one.
Right. Okay. All right. Thank you.
Yeah. So you have 3 assessments, 1 quiz, 1 written, 1 oral. All right. Any other questions, admin sort of side of things?
All this information, Georgie, you'll put up obviously in the assessment section on Milo. So if you know, a lot of information to take in a short period of time, but if you want to go back and have another look, Georgie will have that. And the idea behind this is to sequentially release this so that you're not overwhelmed by the information, because there is a lot to take in. We have a cunning and devious plan to make you feel relaxed and comfortable and confident with the ECGs and how it relates to the patient.
Yes.
So-
Jenny, is the Viva in the assessment period? Yes. So that's one of those 4 assessments that I'm talking about. So you'll have our subject, then you'll have your obstetric subject, and you'll also have your placement subject. You'll have 4 different pieces in that assessment period. Some of us had placement week 4. Interesting, Indiana. Okay, well, if you have placement week 4, you might need to put in a deferred for, if you have it on that on the due date, you'll need to put in for a deferred for the next week. All right. Okay, well, we're gonna keep going then. So this is more for a version. We'll kind of see how this goes over the coming weeks. So basically, obviously, we're going to be doing a lot of ECG interpreting, and it's great if we can sort of explain our reasoning. So I'm hoping to use a whiteboard for the semester so that we can both interact with it. But let me know if it doesn't work after a couple of weeks, and we'll change tact. So I thought we'd start off with, mostly for Anita and my benefit, to get to know a little bit more about you guys. Sorry, let's go my presentation mode. So to start off with, each week you'll have seen in the tutorial lesson plan that I put the learning objectives up there. That's what we're going to cover in the tutorial. So if it's something that you're particularly nervous about that week, try and make sure that you attend the tutorial. You'll see in the beginning weeks we're doing a lot of identifying, and in the later weeks we're going to go a lot more into our assessment and management. So that's kind of what you can expect from the tutes that we've just discussed. So hopefully you should be able to interact with this on your own, but mostly for Anita and my benefit, it'd be great if we could fill out a notepad each about what you guys find the trickiest part of ECG interpretation is, particularly for you. If you don't feel comfortable, you can type in the chat if you prefer. Put your hand up. Anita says. Olivia's group, you guys can just verbalize if you guys want.
Does sound easier. Remembering which waves and which complexes make you which 0.12 or like 0.2 of a thing.
Sorry, Olivia, your sound's a bit funny. Classic. Anita says being confident with each of the complex and what they actually mean. I like that we have ECG from people in real life isn't as clean and easy to read in those as those in the textbooks. That's a really good point from that person. Who said that?
Is my audio any better now?
Yes, much better.
Wonderful. I was just saying that for me it's difficult to remember which complexes and waves need to be which size, like whether it's 0.12 of a second millimeter.
Yeah. Also, remembering the values sometimes I find is a little bit hard. I agree, and I think that what's beautiful about ECGs is that, and certainly for us, is a lot of the time we're reading it so much on the fly, and the expectation is that we are reading it on the fly, is that those smaller values we kind of brush over a little bit sometimes for a quick recognition. Would you probably say the same, Anita?
Yes, there's a lot of pressure, especially if you've got an unwell patient. And I remember the first time someone gave me an ECG, it was a 12 lead, and I was on placement as my boots were shaking and I was very nervous, and they handed it to me and I attempted to interpret it upside down. So that went very well, as you can imagine. I didn't
a
know
beautiful
which way was
story.
up and which way was down until I read the bottom, which said diagnostic. And I thought, oops. So I just turned it discreetly round and said, I've got no idea, sorry, because I hadn't done the ECG class yet. So, yes, a lot of pressure is put on us to read ECGs, especially with with an unwell patient, to look for what's happened, what's going on with the patient. But again, remember, it's mapped back to that patient's presentation. It's just another tool that we use. And yes, there's lots of complexes, waves, segments, intervals, all in there. And having to know those, yes, to remember it. And people have cheat sheets, people have little charts to help them along the way, just like we do with our drug doses. What's wrong with that? Nothing. I'd rather just double check it and get it right than sort of go, oops, oh no, you're walking and talking and it says asystole. No, that must be an error somewhere. But yeah, there's nothing wrong in feeling overwhelmed by it. I understand that completely, and so does Georgie. It is a lot to take in. And yeah, what you're writing there is spot on.
Yeah, and you know what, like hopefully through this semester, Anita and I can tell you all of the mistakes that we've made so that you can learn from that. But you know what, the thing is that we do have mistakes, and the hope is that you're working with someone who supports you in getting over those hurdles and the lack of confidence I think sometimes that we have with ECGs. I saw some people saying, so understanding, does the person understanding the correspondence of the axis and of the heart in the different directions of the electrical signals, does that mean, does that person mind speaking up to their point? Was that mostly talking about the 12 lead sort of side?
Might be axis deviation or angles
Yeah.
of different
Right.
leads. Oh, a giving. So in other words, what are inferior leads? What aspect of the heart are they looking at? Is
Yeah.
that what that person means? Yeah. As a lateral lead, where are they looking in at, sort of thing? Is that what that
Yeah.
person means? Okay.
Exactly. So sort of, because you start with learning how to sort of read the ECG, but actually understanding how that relates to the physical directions of all the electrical signals in the heart is sort of the connection that I find difficult to make, which makes it hard for me to remember the actual interpretations.
Absolutely.
Makes
Yeah.
sense.
Absolutely. A teacher once told me when we moved from like just, lead 1, 2, and 3 and those augmented leads, AVL, F, they said to me, imagine that you're sitting at a dining room table and you're there having your favorite food. I don't know, for me it'd be sushi or something like that. Maybe you've got spaghetti and you're sitting at a dining room table and you're in a house where you've got windows all around the dining room table. Now, if you're facing me and I'm eating my sushi, I might, you could see me doing that. But the person behind or the people looking through the windows from behind are going to get a different view to you looking face on to me. And the same token, the people outside here laterally are going to get a different view as well. So, for instance, if I spill it down the front of myself, the people at the back might not know because they can't see it. So think about those windows looking in. They all give a different perspective or a different view of the electrical pathway as it travels down through the heart. And we'll go over this 100 times, but if you try and imagine it like that room with the windows around it, it affords us that extra view. So we can see more in the literal sense of the electrical conduction activity. And I don't know, is your favourite food sushi or something else? But you get the idea.
Something messier. Yeah, so we're going to cover that a little bit today, Ren. So hopefully we start to talk a bit more about it, and the frequency helps with that too. Okay, so we might move on from our first activity. We're going to talk a little bit case context. As I said before, we're going to try and keep it case perspective with a lot of what we do. So to start off with, we're going to talk about the 58-year-old male with chest pain. And hopefully this is the kind of presentation that was probably first introduced to you. But what do you want to know particularly about the 58-year-old male with chest pain and why? You can pop in a note, or you can whatever, type in the chat or put your mic on, whatever. Honeyacre Street, Indiana. You're going to need to be a bit more specific than that. PQST. Yes. Why is PQST important though, Sariana?
Because it can tell you quite a bit. Like for example, if it's like radiating, is it like a heart attack or like the different, like it could help you like start understand, is it like angina or is it an actual myocardial infarction and so on. Like there's like small hints that you could get from the PQRST.
Yeah, so like what would be giving you that specific hint about that? So you said something about angina. What does that mean? And why is that?
So like angina, like if the pain stops at rest, like that could possibly be like an indication.
Yeah, for sure. Yeah, definitely. So the type of pain and when it's relieved is definitely a big factor and a big part of that. And why does that happen? Sorry to put you on the spot. But that's what this
No,
tutorial
that's
is
fine.
about. Yeah.
Because like angina, it's not like a complete blockage. It's kind of like a warning system. So it's like it will stop if you rest, but like it just tells the person that there's an issue here, and you need to solve it before you die.
Yeah, for sure. Yeah, so so he's talking about that particular element of that occlusion and the vasospasm as well there. So yeah, that gives us a big hint about the type of pain that we're talking about. So Lara, you've talked about family history and medical history. Why is that important for this patient? Or if Lara can't speak to it, anyone else can answer for her?
I guess there's a genetic predisposition there too, isn't there? So maybe that's what Lara meant, history, family history, medical history of chest pain or cardiac. And I think someone else has put in the chat in their history of risk factors that sit in there, both the age and the gender or the sex of that person also is potentially a risk factor there as well. But yeah, is that what you meant, Lara?
Yeah, strong genetic correlation. Yeah, it's an interesting point, and to your point, Anita, like we talk about the genetic correlation and in cardiovascular risk factors, and Anita and I are going to talk to you a little bit in a minute about something else, but that genetic correlation, sometimes we don't understand if that's more epigenetics or biogenetics, that we're the reasoning behind why we have that cardiovascular disease risk factor. So for example, talking about more about the social determinants of health and how that's framed how we interact with those risk factors growing up versus are they risk factors because of our genes as well. And I don't think we even fully understand that yet, but it's a really good point about how that can frame how we interpret that chest pain for that 58-year-old male. Also talking about other things like other risk factors, including those highlighted by Kate and Kelly as well, with other specific health conditions. So going on from the 58-year-old male with chest pain, what is probably the problem that we have in cardiology with a lot of what we know about cardiac care? Leading you down the garden path here.
Love a good garden path.
Why do we know what we know about cardiology in general?
Where's all the information come from that we know?
Research and smarter people than us.
Yes,
This is true.
Definitely.
Who were the
Always smarter than
subjects that they tested, or where did they get that information from, those smarter people who did the research? Who were the participants, or even who were the patients?
People with cardiac issues.
And if you were to Google right now, heart attack, what image do you think would come up? Describe to me what the typical person in society, in Western society, looks like. An overweight. I've got
And-
a weird sample, but yeah, overweight male. Sorry, George.
An older gentleman, I guess. An older gentleman clutching his chest, looking very pale.
Yeah, for sure. Kelly talked about that as men, and also Kate, the overweight male. I think what's challenging about this is that we often reach for this kind of presentation because it's the type of presentation that we have studied over so much time, as in since we started studying cardiology and heart attacks. And so unfortunately, like littered throughout all of that research that we talk about is an overrepresentation of chest pain and cardiac presentations from like an older male perspective, and particularly an older white male perspective. And the reason we're just sort of highlighting at the kind of forefront is because we want you guys to start thinking critically about how people present with chest pain or cardiac conditions in general. We're going to talk about a lot of bit about the way that people present. And Anita's going to present a couple of little slides as we go, talking about the inequality in the research and what that correlates to in terms of our outcomes. Is that all right, Anita, if we go on from there?
I've got a few screens here. I've got to find my unmute button. All right. Do you want me to? So I'm just basically going to talk about what we're basically a knowledge gap that exists for us, and in terms of the information that we have. So there is a gendered inequality in the context of cardiovascular or cardiovascular disease. And if we just pick Australia because we're here, gendered inequality. So gender inequality means that there's an unequal treatment or perception of people, individuals, based on their gender. And gender, basically, when we define the term gender, it's a social construct. So, developed in the form of socialization, how we live, how people are supposed to act, look, behave, is a social construct. But how people are perceived is part of that. And when I just asked you, and Georgie asked you before, if we were to Google the image, not one person here put up an 18-year-old woman or an 18-year-old trans person, for instance. So the image we have is of this, and it's quite right. We've got, there are a lot of overweight older men who do have acute coronary syndrome that is either angina, unstable angina, all the way through to an infarction. But if we as healthcare clinicians think about that, that's the only type of presentation that will be, hello, Kat, then we'll miss all these other people. And that's where the problem lies, because now we're beginning to see in the research that there's a significant knowledge gap. And that's what we want to sort of talk to you about here. And this knowledge gap can mean that 23-year-old person who identifies as female is short of breath and has a mild ache in their shoulder. Now, as a clinician going in, you might think, okay, is it anxiety? Is it this? Is it that? But if we go in and we already have ruled out the possibility that it's a coronary event or a cardiovascular disease, then we're not doing that person justice, and we're offering unequal treatment, and that unequal treatment translates into differences in health outcome. In other words, the time taken to receive an aspirin, for instance, is on average about 53 minutes later. There's a difference, and I'm just talking binary for the moment, and I'll talk transgendered persons shortly, but there's a 53-minute delay in between a man and a woman receiving an aspirin for the same condition. And aspirin, as we know, is an antiplatelet agent, and it's important in unless they're contraindicated in the part of the management spectrum for all these patients. So this gender bias exists as a knowledge gap for us in society. So there's also the misperception of what happens between, and again, I'll just talk about binary in a minute and open up shortly. But for instance, in that history of data, it's based on male patients, based on male rats. The use of other genders was only recently introduced. So, for instance, how do you factor in the risk factor of menopause, preeclampsia, eclampsia, ovarian cyst, polyovarian cyst disease? All these are also risk factors that can impact cardiovascular disease. And as clinicians, we need to be aware of that. This also translates through to women. And again, I'm talking, and I'll expand it open in a little bit minute, but women themselves don't recognize their own symptoms of or signs that something's wrong. So they'll, there's a knowledge gap even at the population level for, if I'm short of breath or if someone's short of breath, that's nothing, that doesn't exist. So I think when we asked you before, I think a few of you actually gestured as a white, overweight male clutching his chest. So if it's not 10 out of 10 chest pain, then it's not a coronary event. So that's the issue that we're sort of, as clinicians, trying to think about. If we go in there and, we see 7 out of 10 and they're all white men, overweight, clutching their chest, what happens to the underweight white male that's clutching their shoulder? Do they miss out? And then let's make that even broader to all genders. So this translates through to, for instance, women will experience more diverse symptomology than what men will. They will have the shortness of breath. They may not have the 10 out of 10 central chest pain with radiation. They may have more subtle symptoms. So when we asked you initially, that 58-year-old person, what are the questions that you want to ask? We're going to unpack that a little bit further and think about, what is significant for that person in their body. They've lived in that body for all that time. So if they're telling you they've got toothache and it's a sudden sharp onset, what's happening, then listen to what they're saying. And what does this translate through? A 2023 study in Victoria found that women were less likely to receive guideline or concordant care, meaning they had the aspirin, they had the bloods, went through the whole from assessment of pre-hospitally assessment in hospital, but also through the hospital treatment to discharge. And I guess you can gather from that women's outcome for a coronary event is, even though their presentation is different, they are less likely to survive than men, and they have poorer health outcomes. So their degree of inability or their health challenges moving forward because of the event that they've suffered are more significant. So there's not only a gap in knowledge, but that is a gap in our knowledge as pre-hospital clinicians, but also in the medical field, and through all the way through from assessment to management, but also to discharge into the wider community as well. And if we just stop for a moment and think that gender, we've talked about binary male female, but let's just open that out now to transgender persons. So here we think about transgendered person, how their gender, how they define themselves, identify themselves, actually interacts with social determinants of health to actually create an even worse outcome for this population in terms of health risk. And they have an increased burden of disease, what they call for cardiovascular health disease. So we know in Australia, we just said it ourselves, that cardiovascular disease is mainly an overweight white male person's problem. But when you look at, actually drill down and look at, okay, transgender persons, whether they have had surgery or whether they've had sex-affirming hormone therapy versus not, and we all know you don't need to have surgery and or hormone therapy to define yourself to be a transgender person. But when you compare both of them, both outcomes are worse than the population of, if we just compare it to cisgendered people. So one of the reasons for that, and we look at the social determinants, if I were to ask you right now, what do you reckon would be something that you could do for yourself to oppose or reverse your risk of cardiovascular disease? You probably say, I'd eat more vegetables, eat more fruit, smoke less, drink less, exercise more. So here's where the social determinants come in. So for transgender people are often subjected to minority stresses, and stresses we know is also a risk factor there. So stigmatization, discrimination, for instance, if you don't feel safe in public, if you can't, if you don't want to feel safe going for a walk, how do you get that exercise? Which change room do you go to in the gym if there's not access there for you? So just thinking about access to those social environments that create a social determinant there where people aren't able to access healthcare or access even exercise. So I guess what I'm trying to say here is that we've got a whole range of people that are all equal and all are deserving of our assessment in pre-hospital care situation as clinicians, and in the hospital system and in society. And if we now think about what is a person who's having a coronary event, it's not just the 50-year-old male who is white and who is overweight. And yes, they do exist, but we need to be able to incorporate everybody in that, because we will miss somebody. And here's a story, here's an example. So I was on placement, like you will be. I was only a newbie. I just graduated. Yeah, I just graduated. And I was working with a experienced clinician, and we went to this person at 3 o'clock in the morning, and they called us for toothache. And the toothache was severe enough at 2 o'clock in the morning, and we hadn't got back to the station and we hadn't had a meal. So we were cranky, as you get when you haven't had any food. So we go to this job, and this person has poor social hygiene and poor dental hygiene. In fact, they really only had 2 teeth left in their mouth. They had a recurrent history of abscess from poor dental hygiene. So yes, I think when it comes to toothache, they were probably the master of knowing what toothache felt like for them. But something's different. We came back to that question earlier of, okay, what are the questions you want to ask? This person's called us at 2 o'clock in the morning. They haven't just taken a Panadol. This pain's exceeded that. And my partner is like, okay, we'll just give them some Panadol. Let's just go. We've got to get out of here. It's 2 o'clock and I'm hungry. Yeah, I am too. So I'm like, no, there's something not right. They were pale, they were diaphoretic. They didn't work well. So I said I wanted to do a 12 lead on them and explore the history a bit further, to which my partner was like, you knew, and you want to do everything that what are you doing that for, in other words? So they went and sat in the truck. So that was great. But anyway, so I pursued on and I did the 12 lead and asked further questions. And this was a sudden sharp onset of pain just in the jaw. And their 12 lead came back with ST segment elevation in leads 2, 3 and AVF greater than 2 millimeters. They were having an inferior infarct in front of us. And the only pain that they had, or the only altered sensation they had, was referred to their jaw. And yeah, sure, they had an abscess in there and they had pain from the abscess, but they didn't normally wake up at 2 o'clock in the morning from this. So from that and the extended history that I did, partner came back in and we looked at the ECG and basically we transported that person through to hospital, and that person was treated to the best of care that they could have. But the point I'm making is I could have just left the blinkers on, but that person's telling me something that was significant for them. And as I keep coming back to that same point, they know their body better than you do. They've lived in it for X amount of years. So if they're telling you something significant's happening, the woman who normally goes 10 metres up a hill to hang out the washing, she does it every day or every second day or whatever. For the last week, she's been breathless by the time she gets to that washing line. Something's changed, something's different for that person, and it's worth exploring why there. So just thinking about that in context, that's the point I'm trying to make, is that not everybody, just like with trauma, just like with asthma, just like with every condition we go to, if we think that we can make a person have whatever we believe, we can bend the signs and symptoms to match what we think it is in our mind. Oh, that person's got, a tooth abscess. And sure, febrile, sweaty, pain in the tooth. Absolutely, they match, but there's something more going on. So that's just my point that I'm trying to make, and I will be quiet now because I am talking a lot. But yeah, that's just my point that I'm trying to make in terms of blinkers and seeing past that and thinking about where the information that we know comes from in terms of how we analyse and manage an ACS event.
Thank you so much, Anita. So just as a bit of context, Anita told me that she had done this research with was with Victoria, with Monash herself. So
Uni of
well,
Melbourne. I'm studying as well, so I'm doing a master's in into a PhD in gender equity. So I have an interest in equality, and I also obviously am a critical care paramedic. So I have an interest in paramedicine. So keeps me off the streets and here with everyone. Just joking. All right, I'll be quiet now.
So I guess off the back of what Anita said, have you guys experienced this on your placement about sort of this downplaying of the person's signs and symptoms, and did that challenge you particularly? Or everyone's preceptors were perfect?
You can put it in the chat if you want.
I had a person on placement. He was like must have been a 50-year-old gentleman, and he went down to check the mail, and his wife noticed he was a little bit out of breath when he got back to the house. He was fit as anything. He did marathons and all sorts of stuff. And the only thing was he seemed a little bit puffed. And they put the leads on, and he was having a STEMI as well. So off we went and off to hospital. But yeah, that's all. He was up walking around. He didn't have any pain. He was just a little bit puffed, and it just wouldn't go away.
Yeah, that's a really good example, Jazz, of the typical presentation that we talk about in the textbooks just doesn't. It does happen in real life, but it just it happens, in my experience, less than you think. Yeah, anyone else? 4 lead went on everyone from Kate. Fantastic. And often a 12 lead if nothing showed up, but a patient still looked yuck. Yeah, that's really good practice, Kate. And it's really rewarding for us to hear that that does happen in practice, because often I think there's a laziness to do a 12 lead because it's awkward, right? Like you have to take the shirt off, and you know, if they've got large breasts, then it maybe you feel a bit uncomfortable yourself, or like you haven't got the right environment. So that's really good to hear, Kate. All right, so the reason we're sort of talking about this now is because I really, as you guys go through your assessments, please start to draw from this type of literature that gets you thinking a little bit more critically about what is actually going on in the real world, not just from our textbooks, because as Anita has just rightfully explored with us, the textbooks are missing something. They're missing a big gap. And we have years before we probably even get close to understanding that. But please be active in how you look for research that supports your discussion in this, because the more we read about it, the more we understand it, the more or the less likely we are to provide a difference in care from our side of things, and the more we can accommodate for it going forward as well. Noticed female patients were getting a lot less 12 leads than male patients, just a 4 lead most of the time. Yeah, it's a really good point, Olivia, and it is because of that awkwardness, and it is that uncomfortability from ourselves. I think, you know, I don't think the patient would say no if it was if the environment was safer for them. So it's a really good point, and I hope that we're not the paramedics that are saying it's too hard, or that we're feeling like, you know, there's a more experienced clinician, as Anita says, that's kind of like, nah, don't worry about it, it's not important, because it's just not. It's, you know, it's 6 sexual leads. So it's a really, in saying that, you know, sometimes if I was working with someone who really didn't want to do a 12 lead on scene, we're going to talk about Einthoven's triangle now, but remember, you can still press the 12 lead button even with 4 leads, and it still gives you 6 views. So if you do find yourself working with someone who really doesn't want to do an ECG on scene, and you really are like, we have to wait to the truck, at least do that 4 lead with the 6 views, if you can, because that still tells you a lot, and we're going to talk a little bit about that. Are there actual taking considerations in male versus female 12 leads or not? Good point, Gareth. And I think we're really bad at that in general, of of providing a safe environment for male and female. But anytime we take anyone's patients off, for anyone's t-shirts off, I think it's really bad practice that we have been assuming that men are okay with us, removing their shirts. I think the same principles still apply, and I'm not really sure where that's come from, if that also has been from a gendered sort of idea of how we're okay looking at men's chests but not women's, or I don't know, Anita, if you have any thoughts about that, but I would say that probably.
Yes, I agree. Every person, I mean, it doesn't matter what gender they are, just as you say, it's quite easy to put the the other leads on. You don't have to get in there and do the 12 leads straight away if you're out in the middle of a a road or wherever, and you can do that in the back of the truck, and you can still access some lead views. But yeah, there is dignity consideration. I think you already mentioned it, Georgie, how you handle person's anatomy.
It's also very still.
Anita, I think you've cut out, or is it us?
No, she's frozen.
No,
Yeah, Luke's like,
Luke, you're very still.
he's locked in.
Hey, he's
It, it might be the uni Wi-Fi because Georgie was frozen too.
yeah.
Not quite sure what happened there.
Sorry. I think it is the
Well,
uni
that's
Wi-Fi.
We'll fix it.
There we go. What happened? We just were transported somewhere and came back.
Sorry, I think the uni Wi-Fi dropped out because I was like, my Wi-Fi
is that what it
disconnected.
was?
Yeah,
Anita,
both of you dropped out, Anita and Georgie. You just both froze on screen.
we were definitely really excited to hear about how you handle people's anatomy.
Thank you.
Yeah.
People's anatomy.
Way to
It's
kick
like
us out, guys. All
no
right.
deal. I'm out of here.
We get the point.
Yeah, all right. We can't talk about people's anatomy. We're going to have a bit of trouble then, aren't we? And of course, Georgie.
Well, you're breaking the internet, Anita.
I probably have, yes. But anyway, yes, allow the person to move their anatomy out of the way, or if you're going to move the anatomy, use the back of the hand, and just be dignified in the way that you do that. Adipose tissue, breast tissue, all needs to be moved so you can get as flat a surface as you can to be able to put the electrode on. But yeah, asking the person to move their anatomy or adjust their anatomy is a dignified way. And you're absolutely right, Gail. Men, women, all persons have require consent and dignity when applying ECG leads.
All right, so we might move on to our next activity. This is a bit of a revision and hopefully pretty comfortable for most of you guys. And I would encourage you to do this next activity not looking at Google, YouTube, whatever, because it's sort of like a little mini test for yourself. But you can if you want, whatever. So in smaller groups, we're going to break you up into breakout rooms. We're hoping that you guys can get your own version of a diagram going about the electrical conduction pathway and how that correlates to the different waves that we see on the ECG. If you want in your own sort of breakout rooms, or if you, like for example, Olivia's in a group there, you guys could just do it on paper. Just draw it together and you can do that in your own whiteboard. And then maybe take a picture of it and then you can paste it into the bigger one. And we're just going to revise that because that will lead us into our next discussion about Einthoven's triangle. Does that make sense? Any questions about that? No. All right, so I think we probably need about 10 maybe rooms.
We've got 38 participants, Georgie.
Perfect. So
are they all doing
perfect.
each one of those, or are you giving them a topic each, or is everyone doing from SA to waves and segments?
Everyone's doing from SA to waves and segments.
Okay.
So yeah, so please try not to use Google because obviously this is meant to be you testing yourself. So, but whatever. All right, so I'll create some rooms. Anyone has, and remember to take a picture of it before you finish so that we can see everyone's. All right, let's go. You can have 5 to 10 minutes.
You want us to pause your recording while we're on pause? Hello, thanks
Sorry.
again back from the breakout room. We're just talking about Ivanhoven's triangle, and thank you, Emma, for reminding us. Georgie, you may have to say what you just said then. So yeah, the different here, you've got different leads on, so you've got lead 1, lead 2, and lead 3. Notice there's a positive and a negative aspect. If you blow that up a little bit, Georgie, people might be able to see the positive and the negative aspect there. So for instance, lead 1 is going to compare the action potential of the right arm to the left leg, and note there's a positive and a negative. So there's a positive and negative aspect to it. Lead 2, for instance, is going to compare the right arm to the left leg, which Georgie was just talking about. And then lead 3 is going to compare the left arm to the left leg. And between each of those, you see the stick there, lead 1 across the person's arms, and you've got the one down from the arm to the foot, and then in lead 2, and then in the lateral side, you've got the opposite. So they make up a triangle. And basically, these bipolar leads, because they're positive and negative, they will map the electrical current, the depolarization and repolarization as it moves through the heart. But because we're looking at different angles or different views, Georgie, if Georgie's here in lead 2 and she's drawn herself down the bottom here, she's going to see a P wave, QRS, and a T wave. But if I am over here in lead 3, it will look different because I'm looking at it. It's still traveling past, but I'm looking at it from a different angle. So maybe, for instance, my P wave might not be as prominent and as it's still going to be there, but it's going to look slightly different because each of these leads are looking at the view of the electrical activity, the action potential, the depolarization and repolarization. Remember, the T wave is the repolarization. So each of these is going to look different depending on the view that we are looking at. And when we use Ivanhoven's triangle, all it is showing us that there's here there's 3 views. We've got a lateral view in lead 1, and we've got 2 inferior views, and you can see that because look at lead 2, you've got it happening from the arm down to the foot. Now look at the next picture, lead 3, you've got it happening from the arm down to the foot. So out of those 3 leads, I would argue that lead 2 and lead 3 would look the most similar because they are looking at the action potential, the depolarization, repolarization from a similar viewpoint. Whereas if I'm looking at lead 1, you can see it's the negative is starting on the arm, the right arm, and going to the left arm. So I'm going to see a different view. So when we look at an ECG strip, we will notice that our inferior leads, our lead 2 and our lead 3 here, for instance, are going to look slightly different to our lead 1, which is a lateral lead. And if we look at the stick, basically where it is, that's showing you the direction of current, how it's flowing from a negative to a positive. And that's what Georgie's saying, is that she's down the bottom there in lead 2. You can see she's drawn herself down there at the bottom in lead 2, and she's looking basically at the action potential coming straight down towards her. And that's why we use lead 2 as our normal monitoring lead for ECGs. But I'd argue that lead 3 would look quite similar to it. Does everyone sort of understand? Does that make sense for people? Is that what I'll get quiet. Any questions? Yes, I'm saying yes. Okay. So all these ECG leads are doing is looking at a different aspect of, and Ivanhoven's triangle is basically those bipolar leads. You've got a negative and a positive electrode. Current is moving towards one of them. Hence, from that view, from the lateral side, I'm going to see a P wave. Sure, I'm going to see a Q, R, S, and a T wave, but it's going to look slightly different to the view that we're going to see down the bottom when we're in a lead 2 or in a lead 3. And I'll just be quiet.
You're talking it. I love it. That's why we have two of us here explaining everything to you.
We are the SA and the AB. No, if we get down the Purkinje fibre, then we're I don't know, we're at a slower rate.
Anita's definitely the AB note, just in case we're clear, because she's definitely keeping us on track.
AB.
So what is really, really an important part to take away from this is that in each of these leads, we have to know where we're looking from. So from lead 1, we're looking, well, I guess you can pop in the chat. So from lead 1, where are we going to be looking at the heart from?
Is there any way of blowing that up just a little bit so everyone can see it a bit more? Or is that the size we've got it,
You know
Georgie?
what? I think
If we're going to
Could you
muck
see
it
me
up,
now?
don't worry. It just might be.
but, you might have to just navigate it yourself.
Yeah, okay, Roger.
I don't know why Emma Bagley is presenting, so I should present.
So we had someone put in the chat there your last question asking where does it look from? I think we had left LA, so left atria.
All
So
right,
this
there we
is
go.
lead 1. That's it, lead 1. So there you can see C and C, you've got lead 1, you've got a negative electrode there, and you've got a positive electrode. So the current's going to flow towards, and you're exactly right there. Right arm to the left arm, because that's where your positive electrode is. So well done, Olivia. Liv.
Fantastic, Olivia. So we're looking at the heart from that left arm. Okay, so lead 2, we've just talked about. We're looking at it from which direction?
Find that positive electrode. Where is it?
Left leg. Fantastic, Olivia. Cool. All right. So what's our right leg doing then? What's the point of the electrode in the right leg? Because we put the 4 leads on, right? Why do we put that one on? Earth. Yeah, cool.
Yep.
Olivia's right on it today. It basically doesn't do anything. So in hospital, sometimes you see, I think they have, Nita, you might know this, but do they have an earthing built into the ECG monitor? I believe
Usually
as
that
well. They have-
Wilson central terminal that basically that's where you get that augmented lead from. So it
Yeah,
sums
so
all
they
the
don't have to
action
put-
potentials that occur. So we're talking about limb leads here, 1, 2, and 3, but we also have the augmented lead. So the summed, and that uses that Wilson central terminal. All that means is all the action potentials, all the depolarization, repolarization, it uses that, sums it up and uses that as a measure to compare the voltage of the other leads. And that's where you get with the AVFs and the AVLs and the AVRs, that's where you get the positive and negative deflection.
So lead 3, obviously we're looking at it from the left leg as well. But where things get a little bit tricky is in the other unipolar leads. So essentially the reason these leads are a little bit tricky is because, as Anita just said, there's that central point, Wilson's, what is it called? Wilson central point, terminal point.
Central terminal, yeah. So that basically adds them up. That little A there stands for augmented. And that A is what that little A is what it stands for, augmented, meaning it's summed, added up. So you can see these are unipolar leads. And you can see if we pick AVF, for instance, there is only one deflection here, isn't it? There's no negative, and there's no negative, there's only a positive. So how does it get the balance? How does it look at a negative if it's only got a positive? So what it will do is it will use that central terminal, and augmented leads are unipolar, and they will use what's called that Wilson central terminal. So it only uses a positive lead as we can see it, but it averages out, it basically looks at the waveform coming down to that leg that we can see where Georgie's drawn the figure, but it will compare it to the average of all the other impulses, electrical depolarizations, repolarizations that have occurred. So it will measure across that. That's how it gets around being only a unipolar, meaning one lead, and you can see one direction, I should say, and you can see it's only got a positive lead. But the interesting thing for an augmented lead, AVL will record AVF, records the left foot potential. So if it's sitting in there as a left foot, as a positive, what do you think its view is going to be more like? Is it going to be more like lead 1 up the top here, or is it going to be more like,
Oh, sorry.
is it going to be more like lead 2 or lead 3? So the question is, AVL, we're looking at the augmented leads, the unipolar leads down the bottom. What view do you think it's going to be most similar to, lead 1 or lead 2 on the limb leads? What do you reckon? Look at the direction of the current. Lead 2, spot on.
Fantastic.
So its view is going to be, it's another inferior lead, isn't it? So it's going to be similar to lead 2 and similar to lead 3. So in an ECG, when we're looking at our inferior leads, they are our inferior leads, lead 2, 3, and AVF. So that's the function of the augmented leads. They and if we look across on the left-hand side here to the little wheel that Georgie's got here, you can actually see AVF. You can see 2, 3 and AVF on the extreme left-hand side of the screen. You've got 2 and AVF and 3 there. They all share a similar pattern in terms of the action potential is traveling towards it, and they will all look similar. Have a look on the wheel here, and you can see lead 1. It's looking at a different angle, so that's why we'll call that a lateral lead. It's a limb lead, but it's a lateral lead. So when we're getting our standard leads, we'll use unipolar. So we've got 2 that's got a positive and a negative, lead 1, lead 2, and lead 3. And of that, lead 2 and 3 are going to be similar. But we'll also get what's called an augmented lead, a small a VF, a small a VL, and a small a VR. And that augmented lead is a unipolar lead. It only has one positive end, unlike the bipolar, it's got a negative and a positive. But between that, it makes up that other side with using that Wilson's central terminal. And I mean, no one's going to ask you an exam sort of question on that, but just so you know, that's how it generates a positive and a negative waveform. Between that, if we added all that up together, you've got lead 1, 2, and 3, and you've got augmented AVF, AVL, and AVR, and they all group together to help you view different parts of the heart.
So to get back to the areas of the heart that we would be particularly looking at. So as we said, the easiest, so this is what Anita was just talking about over here. The easiest place to see what is going on is from right down here. So this is me looking up at the heart. So when I'm looking up at the heart, I'm looking in this direction because I can see most of the voltage coming towards me. Remember, we said Anita talked at the beginning of this tutorial about the fact that she was sitting there eating dinner, and I'm looking directly at her eating dinner. She could throw all of her food towards me. Ideally sushi, maybe not spaghetti.
Maybe
So-
not spaghetti, no.
So this is lead 2 down here. So as Anita said, the most similar view that we're going to see is any other view where we're looking from the bottom, because again, our left ventricle, the electrical current's traveling towards us, and we're going to see most of that current from there. So the reason that we see that lead 2 is because, as you can see, that directly looks perfectly right up at the septum. Whereas if we're standing at AVF, we're actually looking slightly up at the right ventricle here. But lead 3, we're also looking up at the right ventricle. But as we said just before, our left ventricle is thicker and it's more representative. So what we see in the QRS complex is actually that right ventricle, the left ventricle depolarizing. We don't actually see the right ventricle because the left ventricle is so thick. So because of that, which view do we think is going to be theoretically the most useless to us?
Useless, did you say?
Yeah, maybe not useless. Maybe we can't see much in. And why?
Let's just run through where's normal depolarization. Maybe we can put in there, where would the SA node sit on that map? Where would the AB node sit on that map? Where's the bundle of His and the Purkinje fibers? So we draw that on there, we can actually look at the conduction pathway, and lo and behold, there's lead 2 right at the bottom there. It's got the bird's eye view, hasn't it? The action potentials, depolarization, repolarization current is coming directly down to it. So it's coming straight down there. So that's why lead 2 is usually a monitoring lead. Now, Liv's put in there lead 1. Lead 1 is important because it looks at the lateral at the side. AVL is also a high lateral lead, so that's important as well, but good try, Sam. It's a high lateral lead. Keep going. Think about where AVL, well done, Alicia. So that's where basically the current's moving away from that, isn't it? See if it's moving away from the SA node down to the AB, HIS, and into the Purkinje fibres. So we do use AVR for some things. Remember the electric current can go retrograde as well as anterograde, so it can actually move in opposite direction. But AVR is generally always a negative lead for us because the current is moving away from it. Not
Does it
necessarily
look like
backwards,
it
but
backwards
upside down.
Yeah. And because, Olivia, because it's moving the current, so it's starting at the SA node. So we know, so we're positive over here, right? If we're in AVR, we're looking at it from up here. So if we are looking at the electrical current, sorry, it's going to be going always away from us. So we are expecting it always to be negative. So if we see a positive waveform in AVR, what is our first thought?
Maybe I've got my leads on back to front. Have you done that before? I certainly have at 3 o'clock in the morning when it's dimly lit and I'm tired. So AVR have you got an ECG strip there, a 6 lead, like that they could see
No, I haven't, but no, we should.
can I share my screen? I'm not sure if I
Yeah,
can share.
yeah, go for it.
How do I do that? I'm trying to share my
Mm.
screen so I don't know how, will it work? I've got an ECG lead here. If we have a look at this.
SA node failure.
Can you see that okay?
Not quite, Jack. Perfect.
No, it's not working.
Yep, we're good.
Can you see that? Or if I make that bigger, like so, see how lead 2 here, you've got a positive deflection for P wave, you've got a little negative for QRS, nice and narrow QRS, and then up into the T wave. So if we were looking at that, looks a bit, if AVF is the next similar one, it looks quite similar. Okay, we've got positive deflection. 1 is a lateral lead, so I'd expect lead 1 and lead AVL to look similar, but not the same as lead 2. But as Georgie's saying, look at AVR, because the current's moving away from that. See how everything is negative in AVR, negative P wave, negative QRS, and a T wave. It looks completely different to the other leads. And I'll stop sharing now. You go back to your screen, Georgie. Stop share. That's why it looks completely different. Stop share is up here. So when you're looking at that ECG, AVR will be negative because it's moving away from, see Georgie's diagram again, when she gets it up, it's moving the SA node, AV node, HIS, Purkinje fibres. See how it's moving away? So the normal trajectory is down to lead 2, isn't it? That's why we have lead 2 as our normal monitoring lead. So I'd expect a positive deflection in lead 2, 3, AVF, because they're all my inferior leads. I'd still expect a positive deflection in 1 and AVL, but because it's lateral and it's sort of watching by the side, I'd still expect it to be positive, but not as positive because it's not directly traveling towards 1 and AVL. And I would expect AVR to be negative lead because it's basically stood there by itself watching. It's like watching a train go, isn't it? You can see the impulses, but they're traveling away from it. So it's going to be a negative deflection of P, QRS, and a T wave. Does that make sense for people? Yeah, so that I'll be quiet now.
Any questions before we keep going on? No. Okay, so I'm just going to briefly mention what Jack was talking about. So if we saw an SA node failure, what would we expect would happen?
What does it mean though? What does SA node?
Hey V, take over. Fantastic, Jack. Cool. No P waves. Fantastic, Livia. Yes. So if we don't see an SA node, what is going to happen is we're not going to all of a sudden see a different thing in the P wave, although we may if something else starts to fire off, but we just won't see the P wave. So the AV node will take over, and which is where we start to see more ventricular rhythm. So if we have an SA node failure, then we'll see the ventricles pick up the slack. So that's why if we don't see an SA node. All right, so just at the end here, we did have a plan to do a bit of lead to analysis. And there was a little bit of a document in here to do so. But let me just, hold on a second. We might have to do it as a quick activity. We might just do the first 3, if that's okay. So in your smaller groups, I'm going to divide you into 3 maybe, and can we get started on maybe 4 ECGs, rapid ECGs, and we'll talk about them as a group. So hopefully you should be able to download the file just here. So click download, and you can do your lead 2 analysis. And let me break you up again. I'm not sure how that's opened all up, but good job whoever that was.
They've got access to this anyway, Georgie, haven't they? So they can.
They
Otherwise,
should just be able to download it.
yeah. Otherwise, we'll send everybody blind trying to squint on there.
Oh yeah, no, we'll come in here.
Yes. And each of them is doing every one of them.
I think they should just get through 4. So I'll just say at least 4, maybe.
Yeah. I don't know if John and Alira are going to join. Are you online? No.
They've lost.
Do you want to press pause while they're doing there?
I'm scared I'm gonna.
I know.
Okay.
We weren't able to actually save any of those documents because as soon as it came up with breakout room, it covered up the button that you need to click. So I'm not sure if other people are having the same problems.
Oh, okay. Let me try
Can you
and-
access it through your Milo site, Gareth, through the
No, I haven't put
tutorial?
it on
No?
Milo.
I don't think
Hang
it's
on.
on there, is it? I couldn't find
No,
it.
I haven't put it on Milo.
Oh,
Yeah,
okay.
I'll put it
My
up there now.
mistake. Sorry.
I'll put it up there now. That'll take a minute. Sorry.
Are you uploading it to Milo now,
Yeah.
Georgie?
I'm just putting it in here. It should be on there now.
You've got it linked in the chat anyway, so they can get it there too.
Hopefully. Let's see if I can fix that quickly. . Sorry. I don't know why I didn't put it up there.
It's all right. Everyone's got access to it now.
Yeah, so I can download it now. So I've got it.
Awesome.
But I think
Thanks, Gareth.
I think I need you to put me back into the breakout room. I don't
Oh, sorry.
go back
You
in.
also want to hang around
Such
with
a
us.
struggle. How do I do that?
Go to breakout room and assign, isn't it?
There you go.
And maybe John as well. John, are you there? You're in room. Where are you, John? And John, are you online? I think you're in room. Where's your room? No. Can you send John to a room?
Let's see.
Okay, everyone's left that breakout room now, so I'll just
No.
I'll just hang out here until
I'll move you to
Okay.
room 5 if you want. I'll put you in room 5. There's people in.
yeah, go for it. Yeah, there's still people
See
there.
if that helps. There we go. And John, I haven't got John on my list here, Georgie. Whether
That's okay. We can
signed to
we can come back in a minute anyway.
room 2. Okay, I've sent him to room 2, I think. Maybe he's not online at all. Okay.
Will I just give them maybe 2 minutes?
Yeah. What time do we finish? 9:55. They can work on these in their own time anyway, and you can put the answers up for
Yeah,
them.
I'll put the answers up later.
I like the whiteboard, how you can put everything in there and just move it along.
Yeah, I mean, the hope is that it kind of is like a good resource for them over
Yeah,
the course
no,
of the
I think
semester. And then we
I've
can just
never
keep
used it.
adding tabs to it.
Yeah, I've never
Yeah.
used it. I just do the old-fashioned PowerPoint and PDF and draw on the PowerPoint, but this has got everything going on.
Yeah, well, my hope is that they can start to get to use it, but it
Yeah.
is awkward and clunky, I must admit. I haven't kind of
Oh, well, you're
got
far better
there.
than I am on it.
Yeah. Getting there, Anita.
1 foot in front of the other. What do they say? Can't climb Everest in one go. Oh, I wouldn't know what I was doing. I don't know what I just excuse me for one moment.
No worries. There we go. All right, so hopefully we are back and at least you got through 1 or 2. I'll try and put the answers up separately and you can work them out in your own time and then I'll put the answers up. Does anyone feel confident going through the first one with us? No one?
What are we doing? Number 1, are we?
Yeah.
First one.
How are we going to work out the rate? Come on, guys. I know you know this. We're gonna go 5 minutes over time. If you need to leave, guys, just go, but we'll try and finish this off. Okay, so what are our different methods that we can use to calculate rate? 3 second or 6 second? Yeah. 3 seconds, I think you'd be pushing, but 6 seconds, yeah, fair enough. What, I've not heard of the 3-second method before. How do you do that one? Have you heard of it, Nina? I haven't.
I've only heard of guess the
I'm guessing it's half.
yeah,
Same
half of
okay, yeah, fair enough.
yeah. The 6-second
Yeah.
intervals, they count it out on the grids on the paper there.
300
and count how many QRS complexes are in between, is that? Or they've got the 10-second 6 times 10 and count it out that way.
Okay, so if we use the 6-second method for calculating rate for this one, so if this is a 6-second strip, we've obviously got our 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 complexes. Is that right? Am I missing one? Oh, sorry. 6 seconds is between the two points. So we actually haven't got 12, we've got 10. Yeah. So that would give us a rate of 100. If we use the 300 method, how do we use that method, Gareth?
So count the number of big squares between the QRS complexes and divide 300 by that.
Yes, perfect. So what did you get if you did that method?
About 100.
About 100, perfect, matches. And then advancing on the 300 method, what is the other method that we can use?
You could use one of those rulers if you've got one of those rulers and put it along. That's only accurate for a regular rhythm, which this looks like it is, but people don't generally carry rulers. But that's another way you could do it. They usually come free in your textbook.
So in your Hussars textbook, there's a rate calculator of doing that, but that's particularly useful if you're doing like the 1500 second method as well. So importantly, when we get to our lead to interpretation as well, we do want to start to get better at calculating the difference between the atrial rate and the ventricular rate, because that can tell us some interesting things. Like, for example, if we saw the atrial rate at, I don't know, 60 and the ventricular rate was 100, then that would be starting to tell us about some capture not happening from our SA node. So importantly, as we start to go through when we're calculating rate, we're not just calculating the rate of the number of sort of groupings of complexes that we see, but we do need to start calculating the difference between the ventricular and atrial rate. So particularly we're looking at the difference between the P wave and the QRS wave. So either way, we get a rate of about 100 for this one. Okay, so is our rhythm regular or irregular? Sorry, that says rhythm there, but it should be regular or irregular. Regular, perfect. Yep, I agree, Kate. More importantly, is the P wave regular and is the QRS wave regular? Yep.
Yes.
Okay, what about our PR interval?
Point.
0.1? Yes, maybe just over. Maybe just over. But yes, I agree. And the QRS complex, and sorry, was that normal PR interval? Yep, happy. And QRS is also regular. How big would it be?
Narrow.
Little skinny ones. Yep. Okay. I like it.
How wide should the QRS complex be? So if you're going to look at the QRS, look at a VT. Everyone knows what VT looks like. How wide is that QRS? Massive, isn't it? Or is this? So 0.12, good, yes.
Yeah,
It's
perfect.
important to know. And what about PR interval?
That one, obviously not
How
happy yet.
long was PR interval? How many boxes? So that's 3 bubble boxes or 3 small boxes for the QRS complex, or the really, really small little bubble boxes that you can see in there. What about PR interval? How long would that be? Anyone got any ideas? It's the longer that PR interval, the longer the time taken for that travel from SA to AV. And you may, this is where the blocks come in, heart blocks. So normal length 0.12 to 0.2, so 3 to 4, 5 small bubble boxes. So anything longer than that, you've got possible delay in transmission through there.
In particular, we're going to start talking about that a fair bit. So it is important to sort of, if you don't remember the value, make sure that you have a value that you can remember, that you can start to work it out. So for example, you know that it's 3 to 5 small squares, then you can kind of work backwards from there. Whereas if you are trying to remember both, then sometimes that can be a little bit tricky. So if you use one or the other and then just convert with a bit of maths. And our ratio, our PR interval is great, our PQRS complex is normal, and so consequently, what's this rhythm? In the chat, maybe?
Sinus tachycardia.
Perfect, amazing.
At a rate of, it's always important to put the rate because tachy could be anything from 101 to 250.
So we had our rate at about 100, so hopefully that, so we just include that. Okay, so for this week, I think it would be great if you guys can work through the workbook in your own time, and I'll make sure to post the answers up before next week. Also, whilst you're doing that, as I said before, it'd be great if we could start to calculate both the atrial and the ventricular regularity and rate as well, and also start to look at what you could represent that on your ECG. So you know how today we did a little picture of our hearts and kind of drawing the normal pathway through. On your workbooks, try and draw the imagination of how that electrical conduction pathway is running for that particular rhythm in the respective rhythms from the workbook. In particular, that's going to help us as we go through for our 12-lead interpretation, because we can start to visualize what's actually happening with our 12 leads and start to marry that up with our patient presentations. Any questions from where we're up to from that? No. Our patient history activity we have run completely out of time for, so just ignore the last couple of pages in your workbook. All right, guys, we're going to end there then. Thank you so much for all of your participation this morning. So next week, we're going straight into 12-lead interpretation. So hopefully we can start to brush up a little bit. Yeah, go for it, Olivia's group. Oh, you're waving. Okay, fair enough. All right, thank you, everyone. And Anita.
Thank you.
All right.
Bye-bye.
Thanks, everyone. All right, need to stop.